Dr. Billy Caputo. Maybe it doesn't be necessary, but some of you may not know who he is. He's a former downstate student. Did residency here, graduated with me, was chief resident for SUNY Downstate, and then went ahead and was working as the medical student education director at Staten Island University, along with a lot of other chief residents from Kings County. But, without any further delay, Dr. Caputo.
Good morning, guys. Really good to be back home talking to you guys today. I've been looking forward to this all month. Today we're going to talk about my Beast Mode series. We're going to talk about antibiotics. This is actually directed at residents, and this is going to cover stuff that I made mistakes with residents, and I see residents making mistakes today. Let's get into it. So we're going to talk about everyday conditions, medicines we use every day. I'm a simple guy. I'm going to keep it simple. I don't want to get too involved in some of the boring stuff. But let's talk about that. Let's talk about some common mistakes. Every lecture I give on Staten Island, I give a Caputo learning lesson that's kind of tied into the lecture, but a little bit off topic. So we're going to hit that. We're going to talk about cross coverage with antibiotics and what that means, antibiotics with dialysis, and some interactions that you would need to know. All right, so let's start with sepsis. So we're working in CRIT. We get what's called the Dennehy special, which you guys have seen, right? The nursing home, really sick patient comes in. Dennehy, wrote the chart. Diagnosis is sick. And there's not much we need to know about this patient. This patient is going to be admitted. If you're working in CRIT, you're going to see this patient in CRIT. When Dennehy was here, this patient was going to the main ER, right? DNR. Just something I use. I actually review all the sepsis charts on Staten Island. I use a mnemonic to make sure I hit everything. My mnemonic is throw for surge criteria. Surge criteria, widely debated, are they good, are they not? I think it's what we got right now. I use the mnemonic throw, T-H-R-O-W, T for temperature, H for heart rate, R for respiratory rate. The O is or, and that's the one above or the one below. So instead of respiratory rate, it would be PaCO2 less than 32. Instead of the white count, it would be bandits greater than 10%. Okay? Vancomycin is one of our favorite antibiotics, right? We use it a lot. These really sick patients get Vanco. We're using it for MRSA coverage. I would say that 1 gram is probably not enough for a lot of the patient population. There's papers coming out and everything, 1 gram every 12 hours. We give 1 gram in ED. Probably not enough. I want you guys to avoid the 1 gram reflex we have. It's easy to pick off the computer. It's easy for the nurses to hang this 1 gram of Vanco. It's premixed. Just an aside, other MRSA coverage we can give: linezolid, Bactrim, Doxy, plus minus Clinda for coverage. Right? Proper Vanco dosing is going to be 15 to 20, and if you're really sick, you can give 25 to 30. This could actually be up to 2 grams of Vanco. So someone who's coming in that you're seriously considering a really bad MRSA infection, and they're going to the ICU, don't be afraid to pull the trigger and increase that dose, whether it's 1250, 1500, up to 2 grams. There does come a little finesse with this, because if you order anything but 1 gram of Vanco, it's kind of like ordering more than 20 milligrams of etomidate. The nurses aren't going to know what to do. So you have to just be aware of that problem and tell them, listen, this is the right dose based on their weight. I want to give them this much. I know it's going to be a little bit more work. If you want, start with the gram, hang it, and then we'll give them the extra afterwards. Okay? The next thing we're going to talk about is our other broad spectrum agents. What do we add to Vanco to cover everything? And when I was a resident, I would basically use all these interchangeably: cefepime, Zosyn, and meropenem, depending on what hospital you're in, imipenem. I would basically say, this stuff covers everything. I give that with Vanco, I'm good. and that's it. But are they all the same? Is there something one's going to cover that one isn't? Is it going to be clinically relevant at all? And then if I add Venco to one of these agents, am I covering everything? Is there going to be a time where I need to use 3 different antibiotics, or is just these 2 going to be it? So, they are similar because they do cover a lot of the same things. You're going to have gram-positive coverage with basically things other than MRSA. You're going to have really good gram-negative coverage. You're going to cover Pseudomonas, which is going to cover a lot of bad agents. You're not going to cover MRSA, which is why we give Venco. You're not going to cover atypical agents, which is prevalent in some pneumonias. And cefepime with Venco isn't going to give you the best GI coverage either. And that's where it's a little bit different than Zosyn, which I think Zosyn we use here a lot, unless things have changed in the past 3 years. And those 2 aren't going to be enough with pneumonia. So, from today, if you didn't know that cefepime is a little different. It doesn't have a lot of good anaerobic coverage. It's not going to give you good GI coverage unless you mix it with something like Flagyl. We know this, but basically it doesn't have, it's minimal cross-reactivity with penicillin. We use it for a ton of things: monotherapy for neutropenic fever, HCAP, UTIs, meningitis. It's not good enough with Venco for the really sick GI patients. Okay. When you have a penicillin allergy, it's frustrating when you're treating people in the ED and they say you're allergic to penicillin. Most of the time you ask them what their allergy is, and they either say something that's not an allergy, they vomit, or they get nauseous, or their mom told them they were kind of allergic when they were 1 year old and they haven't had it since then. So of the people, which is 10% of the population, 85–90% of people could tolerate penicillin that come in the ED door saying that they have a penicillin allergy. Cephalosporins, in the past they would say up to 15% cross-reactivity. We've known this here for a long time that it's probably more like 1% in the ED literature. When you get to meropenem, it's about the same, about 1%, so minimal. And aztreonam, there's actually no reported cases of cross-reactivity. So really, when I ask them what their allergy to penicillin is, I'm just hoping they're not saying, the bottom picture, which is anaphylaxis. And then, as long as it's not an anaphylactic reaction, I'm pulling the trigger and giving them, all of these. And I think that's starting to show up in the literature where if you have a strep throat and you're kind of allergic, the next recommended agent is going to be Keflex. So let's move. Let's talk about pneumonia now. I actually have an entire lecture for the medical students dedicated to this. But what antibiotic are we going to pick? How are we going to make that decision? This is a little basic, but it's the one time when we're going to choose completely different antibiotics depending on where they are. If we're sending them home, our first line agents are going to be Z-Pak or Doxy, even though people are getting Avalox and Levaquin like it's candy for colds. We're going to take into account if they have recent antibiotics, do they have any HCAP or Pseudomonas risk factors? Am I sending this patient to the unit? I think regularly we're giving people a ceftriaxone or Zithro and admitting them to the floor unless they're going to the unit. But just touching on a couple of Pseudomonas risk factors, they are similar to HCAP risk factors, but yet a little different. Is the patient neutropenic? Are they immunocompromised? Do they have HIV? Do they have any structural lung abnormalities? Or are they on chronic steroids, frequent COPD exacerbations? This is one I want to say, instead of my ceftriaxone, I'm going to add an agent to cover Pseudomonas that's going to give me a little bit better coverage. So my approach to the really sick patient that's going to the unit who has Pseudomonas risk factors is I'm going to choose an agent that's going to be my atypical coverage, which is going to be a Zithro, Doxy, or one of the quinolones. I'm going to give them a typical agent. If they're really sick, I'm going to upgrade from ceftriaxone. I'm going to give them Zosyn or cefepime or meropenem, and then we're going to give them MRSA coverage with Venco, which all of us generally do. Venco is definitely indicated if they have a lung abscess or if they've tested positive for MRSA in the past. So a lot of times we don't know this information when we're in the ED, they had a positive narrow culture for MRSA. So we're going to say, this patient's sick, I'm going to throw the boat at them, and it's my job to cover everything, and then we'll let the inpatient team de-escalate the antibiotics and get a better grip on what's going on. So some pearls for pneumonia. If you're giving Zosyn for pneumonia, you want to use a higher dose. It's been shown that getting a higher, the 4.5 grams instead of 3.375, it gets you better MIC and better coverage for pneumonia. This is actually the only indication that's going to be 4.5 grams. Azithro, a quarter of the time, it's going to be resistant to strep pneumo. So this is why we want to add that typical agent, whether it's ceftriaxone or one of the penicillins. Azithro gets dinged for now being the QT prolongation, and when I was working with Dr. Gernsheimer, if we were giving someone Azithro, we were doing an EKG first just to check their QT. In the New England Journal, it shows that Levaquin also has this QT prolongation issue. So it's definitely something to consider. They didn't find it as much with Avalox. When you give someone a fluoroquinolone and steroids, they have an increased risk of tendon rupture. So if you think about how much you see people on this prednisone course and Levaquin for COPD, it's a little bit alarming. It's definitely not that prevalent, but if I'm going to be on steroids, I probably don't want to be on a fluoroquinolone as well, especially if it's just for COPD, not even for pneumonia. And one of the common myths is you don't use Cipro for lung coverage because it doesn't penetrate the lungs, but that's actually not true. It doesn't cover strep pneumo, which is why we don't use it for lung coverage, and it's not good for monotherapy like Levaquin or Avalox, but it actually does penetrate the lungs pretty well. Okay, so next we're going to talk about our intra-abdominal infections. This is a case of diverticulitis, so let's talk in general about our abdominal pathology. So I can tell you that this is how I think of things, and people can have definitely different opinions and practice differently. So this is just, again, before I start, how I practice. So I determine if the patient's sick or not sick. If they're sick, I'm going to give them really good coverage. If they're not sick and it's kind of that, uncomplicated happy, that chole where you're just, making surgery happy and giving them a dose of antibiotics, I'm going to try and use monotherapy. I'm going to try and give them cefoxitin, cefotetan, and, admit them. If they feel very strongly that they want Cipro and Flagyl, I generally don't mind and give them that as well. But if they're complicated, that's when, this monotherapy isn't going to work. And we're going to go into why. So that's when I'm going to increase my coverage. Definitely at minimum give them Cipro or Flagyl. There are some hospitals that give all these patients just Zosyn off the rip, or Meropenem or something like that. So for diverticulitis, I see this mistake probably a few times a week when I'm working. We get someone with diverticulitis that's uncomplicated, we're sending them home, you're going to give them Cipro and Flagyl. We have a preset prescription for Flagyl, and it's BID for 10 days. And the recommended dose is going to be every 6 to 8 hours, so it's going to be 3 or 4 times a day. So if you're going to actually pull this trigger and give them Flagyl, you got to do it right. So you have to give it 3 times a day or 4 times a day. And if you're giving someone Cipro and Flagyl, and they're taking Flagyl, you're going to be on O'Doul's for 10 days because you don't want to get the reaction of alcohol and Flagyl. If it were me, and I had simple, uncomplicated diverticulitis, I would take Avalox. It's 1 pill a day. You're going to take it for a week to 10 days. It's FDA approved for complicated intra-abdominal infections. If you think about it, it's 7 to 10 pills instead of 50 pills. I can only imagine the antibiotic compliance when you're giving someone 50 pills to take over 10 days. I think they should get, a ribbon, like the people who come back 4 times for their rabies shots, that they actually made it to the end and complied with it. The issue with Avalox, though, for this is there is some insurance issues. So not uncommonly do I get a call from the pharmacy on Staten Island that, we don't cover Avalox, but we could give them Cipro. And there are times where I give them a prescription for Avalox, and I would say, listen, get this filled, and then I staple Cipro and Flagyl together, and I'm like, this is your backup plan in case they can't get coverage. Your insurance company won't approve it. And I don't know if the e-building pharmacy is going to cover this, so it's just something to keep in mind. Out of pocket is going to be $10 to $15 a pill, so for a 10-day course that could be past some people's budget. And this is just the evidence behind it. It was approved in 2005. They looked at it head-to-head with complicated intra-abdominal infections. The first study was Zosyn, which was followed by Augmentin alone. The second was ceftriaxone and Flagyl. And very similar treatment rates. If you had an abscess, Avalox didn't work as well, but it wasn't statistically significant. Otherwise, it was pretty good. I think that if you really looked at this is one of them was for even perforations when they were looking at it, Zosyn, and it kind of held its ground. But again, if I would only use it in the uncomplicated sense. We're going to get into the reason why about this, but here's the evidence. When someone's really sick and you're hitting that, really septic patient or old patient or multiple comorbidities, and they have badness going on in their abdomen, I'm going to break out the big guns. And Unison used to be good. There's a lot of E. coli resistance to Unison, which is why we don't do it. And then there's a lot of anaerobic resistance to some of these medicines, the cefotecan, cefoxitin, Avalox. So when you're really sick, you should probably give them better coverage. You can mix some of those with Flagyl, or just give them Cipro and Flagyl, or give them one of these strong penicillins, these broad-spectrum antibiotics that we spoke about before. But again, outpatient-wise, or the really, patients that look really great, I'm giving them that monotherapy. Or if it were myself with diverticulitis, I would 100% take Avalox and monitor my symptoms. So, all right, this is when we're going to get into my learning lesson for the lecture. So, as a resident, this is really handy. This is my advice to you. So, one of the best investments you're ever going to make in your life is the one you make in yourself. So we're going to cover a couple of topics. We're going to talk about what a one-trick pony is, what the dream team means, and building up your expertise. I think that you guys already did a great job. You picked one of the best residency programs in the country, which I'm proud to be from. Let's talk about that stuff. So what I mean by a one-trick pony is I don't want you guys to be a one-trick pony. I'm not going to lie to you, when I first used Ketofol, I think I fell in love with medicines. I thought it was great. I put someone to sleep, everything worked well, the timing was great, the hemodynamics were awesome. I didn't want to use anything else but Ketofol after that. They emerged. I had a funny story from the kid that I just, put their arm back in place. They were talking about some weird stuff. It was good, home conversation with my wife about, the stuff they were talking about in front of their parents. But as a resident, that's not your job. You don't want to get comfortable with just one way of doing things. You want to know multiple ways, and you want to push yourself to get comfortable with other medicines. So when you have the next reduction, talk to your attending and say, hey, I've never used just etominate for this. Let's use etominate. Let's use morphine and propofol. Get different exposures, because then when you're an attending, it's a lot easier when you've had experience with this kind of stuff, where you say, yeah, I have no problem using this medicine or this one. This person has a severe emergent reaction with ketamine. We can't use that now. What am I going to do? So you want to do as much stuff that you can while you have supervision and get the most comfortable you can. This goes with our next case, which is our STEMI. It's really easy for STEMI to say, code STEMI, ED, open, take this aspirin, take this Plavix, we're going to load you with heparin. And if you don't have an inferior wall, we're going to start you on nitro, and you're going to be out of my ED within 5 minutes. Really easy to do that, but what happens when you're, in a smaller hospital out there and you don't have a cath lab? That's going to be the first time you're going to look up the dosing for TPA, and then have to deal with, is this reperfusion rhythm normal? Is it something I have to be concerned about? What am I going to do? Obviously, I don't want you to TPA people that can go to the cath lab. But I want you to think about it and know that if they're not going to get in the cath lab at an appropriate time, this is going to be something to consider and discuss with your attending. When I was a resident here, I would pride myself on not beating a person I could not put an IV in. I would break out the ultrasound on basically anybody, and people would call me from different areas of the hospital, you know, this person needs an IV, can you come help out? And this was one of my areas of expertise, but I'm not going to just keep it to peripheral guided IVs and do that. I would push myself to get peripheral lines first and get that 24 gauge in, or practice putting that 14 or 16 gauge in. There were people that came in with, you know, head trauma that were fine, they weren't going to bleed to death, and I put a 16 gauge IV in them because it's a trauma, and I'm following trauma protocol, but I want to have this skill mastered when that really sick patient comes in, that I'm getting this line in, and it's not going to be a problem. I've been here, I've done it before. I think Dr. Schechter is back here sleeping, but we probably had one of the best resuscitations ever. It was him, myself, 2 other people, got peripheral lines in, got them to the OR. It probably took 4 minutes. And this goes with, you know, suit splinting as well, to be comfortable with orthoglass and with plaster, even though I think we're still using plaster here, I'm not sure. Intubation-wise, using the bougie, using the glide scope, using direct, and then shoulder reductions too. Don't just have one way of putting a shoulder back in. You should be comfortable with multiple ways of doing this. My advice for improving is to choose the dream team you want to be. You have brilliant attendants here. There are some people who do things great. You know, Dr. Sinner is great at the evidence-based medicine things. If you ever hear Dr. Lucchese with a patient in, you know, down, say, fast track, he's a finesse guy. He'll finesse them up and down and make them feel happy going home without any prescriptions, and they think he saved their life. So, you know, I want to be like Dr. Lucchese with this case. I want to be with Dr. Sinner with this case, where the patient comes in with elevated blood pressure and you don't want to do anything but send them out with proper follow-up. I want to be like Dr. Willis when it comes to, you know, how calm he is with codes. And you get to pick how you're going to model yourself to be. I would encourage you guys to embrace the change of medicine, where something new comes out, new medicines, we got to be on the front line. You don't want to be the guy who doesn't know things and be scared to go back. I think Dr. Silverberg says it great, where he says he's a PGY, I don't want to say too high of a number, but I'm a PGY 7, I'm still learning. And that's not going to stop until the day I retire. If you choose something that you master in, get excellent at it, and then move on. You make sure you're able to teach your junior residents about it. Make sure you're able to teach medical students about it. Be that guy so that when someone needs something, they say, hey, Dr. Copping is a man when it comes to, you know, reductions. Let's call him overhead and get him over here, and then move on to the next thing. And then longevity plan is basically going to be, how am I going to keep up with this stuff? What am I going to incorporate in my normal habits that are going to keep me reading, keep me pushing, keep me driving to know, whether it's, you know, listening to Scott Weingart's podcast all the time, or picking the same day of the month to read Annals. I think Dr. Sinner probably does this, but every good EBM paper that I have that I want to reference in the future, I put in the same area on my iPad. So when I'm discussing a case with a patient, with a resident, I have easy access to this. I'm not saying, oh, I saw this paper, I think it said this. I'm going to say, hold on, you know, I'm going to email you this paper later and we're going to talk about it. So it's just keeping organized, you know, be your toughest critic. And Dr. Doty told me this, but practice doesn't make perfect, but perfect practice makes perfect. So practice things perfectly. So when you're in that hospital, you turn that beast mode on and you walk around with county swag. It's the confidence that when that sick patient comes in the door and there's 3 attendings, that triage nurse is going to say, you know, I'm going to come and I'm going to find the county grad, because they're going to know how to handle this, right? Which happens with my overtime job. Whenever someone sick comes in and walk right past 3 attendings, I could be in the middle of an MI and they'll still come and get me. So at the end of the day, this is basically what we do. Right, so back to our lecture. We're going to talk about UTIs now. So we have a 72-year-old, hypertension, AFib on Coumadin, renal insufficiency, creatinine's 4, not on dialysis yet. They have dysuria, they have an uncomplicated UTI, normal white count. You want to send them home because they're in mid-cert and you don't want to put them on OPS. You guys do that here. So what antibiotic are we going to give them? I've made this mistake multiple times. Are we going to give them Bactrim? We're going to give them Macrobid? Are we going to give them Cipro? Or are we going to give them none of the above? None of the above is the right answer. Right? So let's talk about that. So Macrobid, nitrofurantoin, this is made for simple UTIs. You need enough of kidney function because your kidneys have to release this in the urine to clear the infection. If you don't have good kidney function, it's not going to work. I used to think this would be a good antibiotic because I'm like, these other UTI agents have a lot of drug interactions. I like Macrobid. It's probably going to help based on your resistance cultures. Macrobid's probably pretty good until it changes again. But you do need the right kidney function. So this person with chronic renal insufficiency is not going to work. It's relatively contraindicated when your GFR is less than 45. Absolutely when it's less than 30. So if their kidney function not good enough for a CT with contrast, you shouldn't be giving them Macrobid. If you have someone who's really old, you should be checking their creatinine first if this is a possibility. And you can use it for pyelo. So if you're concerned about a complicated UTI, Macrobid doesn't penetrate the kidneys and you're going to be out of luck. You have to use something stronger. It is pregnancy category B. Again, very small window to use it. Bactrim, I basically call the Miley Cyrus of antibiotics because it's just a wrecking ball if you're on any other medicines. It does have a lot of uses. I love to use it for MRSA coverage. I'll mix it with Keflex for this cellulitis, abscess, PCP, toxo. It doesn't have good strep coverage, which is why for skin we mix it with another agent. One pearl is if you're treating an AIDS patient for PCP, that one double-strength Bactrim isn't going to be enough. You have to give them 2. I think our medicine or EMIM people know this, but maybe in an ED we don't. But you have to give them 2 at a time. You don't give it IV because the IV formulation is basically in minimal supply, so you won't get it. But it affects your potassium, your QT, protein binding. It affects your liver, so it's going to make your INR fly through the roof if you're on Coumadin. It has to be closely monitored. It could affect ACEs and ARBs, sulfonylureas, and it could affect your sugar. Psych meds, dysrhythmics, so it's a mess. Once someone has more than a couple of medicines, I try and stay away from Bactrim, or I'll just look their medicines up, but there's probably 400, severe interactions and over 1,000 mild interactions. So it's just bad. Cipro, we really just don't use Cipro for UTIs anymore. I didn't do it when I was a first-year resident. There's just too much resistance. This does change based on where you are. Even in some areas of Brooklyn, their resistance pattern's okay, and they use Cipro for UTIs. Whenever I see someone on Cipro, I actually cringe when they have a UTI. And I expect them to have, for it to not work. It does have great gram-negative coverage. It will increase the effect of Coumadin as well, so it's not good for someone on Coumadin. It does cover Pseudomonas, one of the good agents. So if you look on the bottom, I do use it for GI stuff. I use it for puncture wounds now and again for Pseudomonas coverage, for prostatitis. Avalox, which is another fluoroquinolone, doesn't penetrate the urine. So this is why we don't use Avalox for UTIs, but sometimes use Levaquin or Cipro for pyelo or UTIs, etc. Okay. When it comes to antibiotic cross coverage, I see this actually a good amount, where I want to cover 2 things at once and want to try and use one medicine. So, maybe here you don't, but we get a lot of high maintenance patients on Staten Island. They have runny nose, they have a symptomatic cold, and they won't leave without antibiotics. You could turn blue in the face telling them how they don't need it, and they're going to want antibiotics anyway. But, so a lot of times I'll go and say, listen, are you just going to keep going to doctors until you get antibiotics? And a lot of them say yes. I am. So I'm like, all right, as long as you know that this could be harmful for you and this could happen, I'll give you a script for it. But there are times when you send their urine out, they have upper respiratory or sinus infection or sore throat, or they're coughing, you're concerned about bronchitis, and you just have a really annoying patient that you want to get out the door as soon as possible. You know they're going to be fine, and they're not going to leave without antibiotics. But if they have a UTI as well, there's a couple of agents that you can use to cross-cover both of these agents. So a couple of the oral antibiotics that I go to are Levaquin or Omnicef. Omnicef I've been using a lot recently. It does, cover UTIs. It's kind of a second-line agent for UTIs, but it covers all your upper respiratory and pneumonia stuff as well. Again, this changes based on where you are, but Levaquin as well.
What is Omnicef?
So Omnicef is ceftonir. It's a cephalosporin. I use 300 twice a day, 10 days, or a week. It's beautiful. So that's it's ceftonir, and it's approved for most of the stuff. For UTI, it's not going to be one of your first-line medicines like the ones I mentioned. It's going to be more of a second-tier agent. Some of the older attendings, use Suprax and some other things for UTI stuff. So this stuff's been around for a while. It's just a newer medicine to use. Our next thing we're going to talk about is dialysis. So what would you guys do in this case? You have a 42-year-old patient, hypertension, end-stage renal, weakness, fever, definitely septic, temperature 103, they barely make urine, but you get it, they're nitrite positive, your chest x-ray shows mild pulmonary edema, and you speak to renal, and you say, hey, I got this really sick patient, I want to give them antibiotics right away. How am I going to do this? Are you going to give it in dialysis? They're like, oh, I got someone getting dialyzed right now, we'll be ready in 4 hours. Who's going to give this patient fluids? Alright, so a few people are going to give them fluids. We're going to give them Tylenol. Who's going to give them antibiotics now? Okay, what antibiotics are we going to give them? Bank and Gent, I heard. Right, so I've been, it took me a while, and I'm not going to lie, I knew Dr. Sinner may be here, so I didn't want to misspeak, because I know he's going to be an expert with this. But our dialysis machines are getting so good that if there's actually even a couple of sites, like, is this drug dialyzable? And, I probably checked 10 to 15 different references, so I wouldn't misspeak about this. But vancomycin used to be really good, where it wouldn't get dialyzed out. Now they're saying between 10 and 40% of it's going to be taken out. And it's very variable in how much. And if you look even at 2000, it would be a lot less than this, where this is changing. Penicillin, cefepime come right out. So they're dialyzable, as is our other broad spectrum stuff, as is our aminoglycosides, freely dialyzable. So you either have to balance and know that they may not be getting 100% the correct dose, and be willing to give them a higher dose, and roll the dice and cover them with a higher dose and make sure with dialysis some will come out, or you're going to hold and give it to them during dialysis. But there's one medicine that we commonly give that isn't dialyzed even today, and Dr. Sinner, correct me if you know something that my research didn't show me, but ceftriaxone is not removed by peritoneal or hemodialysis. It's actually a very complicated thing, so it goes along with how much protein binding there is, your volume of distribution, your size, a couple of things based on how much it's going to come out. But because of the kinetics of ceftriaxone, it's not removed by hemodialysis. There's no adjustments in kidney disease or liver disease. And this is back to what I was talking about, a great cross-coverage agent. Most of our infections are going to be in the lungs or the urine, and this has coverage against both. It's not perfect against the lungs, obviously. If someone's really, really sick, likely this dialysis patient is, you may want to use a stronger agent. But you can know that you could load them with ceftriaxone immediately, and at least you'll have a good amount of coverage. You can talk to renal and get the other stuff involved, but in doing this, a lot of times they're going to say, you know, wait till we dialyze and we're going to give them the antibiotics then. Okay. And again, ceftriaxone has no Pseudomonas coverage, but ceftriaxone is a great medicine. A lot of times we're giving it 1 gram. There are a couple of indications where we're going to do 2 grams. The pediatric EM people love it because you could give like kids a shot of ceftriaxone and then send them to follow with their pediatrician, and they'll have coverage, and that's as good as, you know, keeping them in the hospital most of the time. If you look at our sepsis protocols, you'll notice that less than 28 days you're not saying to give ceftriaxone. And, you know, in residency I had to look this up because I'm like, you know, ceftriaxone has such good coverage. Why do we not give it to these young babies? It's safe in pregnancy. Usually you think it's safe in pregnancy, safe in baby, but there's risk of this biliary sludging, cholecystitis, encephalopathy, but also ceftriaxone calcium precipitation. You can't give them anything with calcium anytime, even within 2 days of giving them ceftriaxone, just because ceftriaxone and calcium precipitates, and babies of this age can't handle that, and it's detrimental. So that's why when you look at these sepsis protocols, they're going to give antigen or cefotaxime. The cefotaxime is going to be used interchangeably with gent in this population. Okay, but it does have excellent CSF penetration. There is a small rate of resistance to strep pneumo, which is why the really sick people with pneumonia, sometimes you want to give them that Zocin or give them that meropenem. And some of the bad bugs also could develop resistance. So I don't want to get too into it, but there are spice agents, Proteus and, you know, Pseudomonas or some of these that can develop resistance to ceftriaxone. But I would feel confident or comfortable giving them this, especially if they're going for dialysis. And then, you know, most of the medicine residents would know. They're going to say, why are you giving them ceftriaxone? You can tell them because it's not dialyzed, and then talk to the ICU about whether you're going to give antibiotics before or after dialysis and how you're going to supplement them, because it could be very tricky. Okay? So in summary, I'm putting it on you guys to change the Vanco culture here. To speak to the nurses, make sure if they only need 1 gram, you give them 1 gram, but there's really sick patients that are, you know, a Brooklyn medium, 100 kilos, probably not going to do anything. And you're going to be underdosing them. So give them the 1,500 up to 2 grams. When you're picking broad spectrum agents, make sure you have the right coverage. If you're, a lot of these undifferentiated sepsis, it's going to be vanco and cefepime. They have a whopping bad abscess or abdominal infection. You're going to need to add to that. If they're having a whopping pneumonia, you're going to give them atypical coverage. Right? We give 3 antibiotics for really sick patients with pneumonia. My practice for the really healthy GI pathology is I'll try and give monotherapy when appropriate. I'll try and discharge on monotherapy when appropriate. But if they're really sick, I have no problem giving them one of these strong agents or dual therapy. When that patient comes in, you could say, hey, you know, I know you have a runny nose, a cough, and you're really concerned, and your urine burns. I'm going to give you an antibiotic that covers everything. Even if you have a pneumonia, this antibiotic is going to work. This antibiotic was made for you. And again, a lot of times I'll turn to Levoplan or Omnicef. Ceftriaxone you can use early in their dialysis patient. If they're really sick, you want to get them strong antibiotics. Just speak to renal about it, speak to the ICU, because early antibiotics are very helpful. And ceftriaxone is a great start with pneumonia and UTIs. So I'm proud to walk out and be in the community knowing that I'm county strong. And thank you guys. That's a great class.
That's a
Wait.
really good class.
There's going to be a day where I say, yes, I did residency with Nikki Joshi and James Willis. So we just need a little bit of time.
Thank you so much.